Great. So today's webinar, titled How Medicaid Health Plans Can Build Collaborative Models to Address the National Maternal and Infant Health Emergency, is brought to you by Progeny Health. Progeny Health is an MHPA Silver partner and has been a longtime supporter of both MHPA and our member plans. And I'd like to personally thank the entire Progeny Health team for putting together and organizing today's session. With that, I'll go ahead and turn things over to our presenters, Dr. Elizabeth Chareau and Susan Toroella, for introductions and today's discussion.
Great. Thank you so much, Eric. And thank you to the MHPA membership. We're thrilled that you're here today and really excited to be sharing thoughts on such an important topic with you. So before we get into the content, I'd like to introduce Dr. Chareau and myself to you. I am Susan Toroella, and I am the CEO of Progeny Health. Progeny Health is, we are experts in maternal and infant care management and have been for over 20 years. I began my career working in maternal and infant health in West Africa in public health. And since then, I've worked across the healthcare continuum. When I think of maternal and infant health, my why is that I really believe that the foundation and trajectory of a person's entire life begins when they're in utero and in those first months of life. And there's research to support that. So when we collectively make a difference and make an impact on a child and a mother, we're really impacting a generation of health. So that is my why. And if I could change one thing about maternal infant health, it would be to increase and solve for the access to healthcare. So that's a little bit about me and what drives me. Dr. Chareau, I'd like to turn it over to you to introduce yourself and the March of Dimes.
Yeah, first, Susan, thank you for having me. I, can't thank you enough for inviting me for the webinar. I'm really excited about today's conversation. Gosh, I am the 6th president and CEO of the March of Dimes, the first physician to take the role. March of Dimes, first of all, 86-year history of really working in public health, right? So they started with FDR back when, right, first crowdfunding, if you will, asking all Americans to send in a dime to the White House to solve for the polio crisis. We shifted towards preterm birth defects, and then eventually, obviously, you go upstream to mom and really trying to solve for the maternal and infant health crisis that it is today. I'm an OBGYN. I've been delivering babies for over 30 years. Excuse me, just under 30 years. I don't want to age myself. But I have been at the bedside, right, in that crisis, and also when it's been amazing. Right. And I would say my background as a provider that shifted towards doing the clinical, moving away from the bedside towards the administrative, and worked for a very large group of OBGYNs in this country, and then shifted to the March of Dimes a year ago. It's actually a year ago last month. I came in as a CMO and then stepped up as CEO. Gosh, I guess it's 7 months ago now. When I think about the why, I think about triplets that I have delivered in my past, and which we don't see as much anymore, and the great outcome they have. They are all in law school, and they were preterm. And I think about the incredible story, and they delivered very preterm, that and how well they did, and all the things that we as a society need to help be able to change. And that, moms and babies have always been at the center of what I do. And I think as I have lived through the last, like I said, almost 30 years, if it's the one thing I really want to be committed to, is closing the health equity gap when it comes to moms and babies. And we'll talk about some of that data today, Susan, but that really is what drives me, as I have been at the bedside doing this, and we really need to solve for this, as moms and babies are kind of the window into our healthcare system. So there's lots of challenges and things to do, but it's kind of what drives me. So,
oh, thank you for sharing that. And for so many of us that have been supporters and fans of the work of the March of Dimes for so many years, we're so thrilled that you're at the helm, and that unique vantage point you have of having been at the bedside and witnessing up close both wonderful stories and also some hardships. So appreciate you sharing that. Before we turn to the agenda, I just wanted to level set with the goals for today's presentation as a reminder that you may have seen when you signed up. And those goals are, we're going to talk about the key drivers of maternal and infant health risks. And then look at, from there, the barriers to collaboration. This whole topic's about collaboration. What are the barriers? And I'm then particularly excited about the third objective, and that is taking a look at some successful examples of partnerships that have worked really well to make an impact on maternal and infant health. And then, most importantly, I think it's what happens from when we leave this webinar, and that is some specific examples. What can we do? What are examples of what we can do to take action and make a real impact? So in terms of the details of the agenda, just real briefly, we're going to look at, I know because you've signed up, you have a keen interest in this important topic, and a lot of us have knowledge. I think it's important to just level set with some of the facts about the state of maternal and infant health, to review those briefly, to level set. And then from there, we're going to look at those drivers. What is driving our crisis in our country? How is it that the United States is at the bottom of developed countries in terms of outcomes? So looking at those drivers. We will have a number of poll questions, so really want your input on a couple of topics regarding collaborative models and the barriers to those. So get ready for the audience participation part. And then after talking about the breaking through these barriers, we then will leave time for what I hope is a robust, and I'm sure it will be a robust Q&A session. So as Eric said at the beginning, as you have questions that you think of along the way, just drop them into that Q&A, and we'll hopefully get to a lot of questions today. So with that, let's dive in and look at some of those facts that I referenced. So
absolutely, gosh,
yeah,
I'm excited. This is where I like to chime in, Susan. This is, you know, I so appreciate you highlighting these and making sure that we level set with where we are today. I often get asked on interviews with the media who sometimes surprise me to say they didn't know it was that bad. So I just wanted to scream that out before. And so really think,
yeah, scream it out. I love it. And I think you're absolutely right. I mean, there's like two categories: people who are shocked as they don't know, and then those that have seen these a lot. We can start to get immune to it, and that we should not get immune to it. This is like not okay. So I like you shouting out. And speaking of, I'd love your thoughts as I'm not going to read these because you can all see them for yourselves. But from your perspective, Dr. Shiro, what like stands out to you most, like jumps out to you of these statistics? Are there one or two that most like trouble you, or most that you focus your attention on?
Yeah, I would highlight, maybe on the left side, when you start thinking about maternal, I think about 80% of these pregnancy-related deaths are preventable. You can look at this as two ways, right? Glass half full or empty. And to me, this is an opportunity. This is where we should be driving, right? Because if these are preventable, we need to solve for that. And that is part of this conversation today of how it takes, this is the burden that we need to really point to figure this out. I would then say on the right side, I go into, I dive into, and I guess maybe because I knew the maternal statistics when it came to Black and brown women, I did not know that Black babies are 2 times more likely to die before their first birthday compared to white babies, their white counterparts. And when I think of that and the health equity gap, closing that kind of gave me chills. And, remember, I'm an obstetrician. So, I deliver a baby and hand it off. And I'm not a pediatrician, not a neonatal intensive care unit, but right, I am obligated to those best outcomes. And so getting that delivery to the best outcome, but then realizing there's still this huge hurdle over the next, infant death is considered 1 year, right? So it just sort of really became, and listen, I'm being really vulnerable. When I stepped in this role, into the March for Dimes a year ago, this data really struck me to the core. That this is where we can, there's opportunity, but then there's this, we've really got to be able to close that health equity gap, because if we can solve for Black and brown moms and babies, we can solve for everybody. And so I think that's where the continued impact, I think it's super important to talk about and really make sure that people are grounded in these facts as we discussed. And I could keep going because I love, this data is what the March for Dimes dives into all the time when it comes to access, which you started talking about, Susan, is kind of around, right, your why. There's a lot of data in here about access too.
Yeah, these, I agree with you on that 80% about it's both depressing because like, how can this be? But it's also, I'm a positive person. So what an opportunity we have collectively to make an impact. So yeah, so I appreciate also how much March of Dimes is doing to make this knowledge available. I mean, this is just kind of like, the top, what is it, eight, facts, but there's so many. So good to be
and
yeah.
It's realizing it's a crisis, right? So the
Yes.
maternal infant healthcare is a crisis at the moment, and that we really, as a developed nation, we are ranked right among the worst for these outcomes. So,
Yeah.
and it's, when I step back to think of that, Susan, a lot of people start saying, okay, we have vaccines, we have sanitation, right? We have some of the basics that should help us move this along. And then it just tells you that our system, right, needs a lot, right, really needs to be looked into. And I do really feel like moms and babies are that window into healthcare for the nation. So and really, this is where my job is to amplify, right, that we have to get people's attention to this. And we can talk about March of Dimes being, we do a ton of education, we do a ton of advocacy, ton of data, right, and research, but it's amplifying the message together is what, right, is so important for this.
Yes. Well, maybe that's a good segue in terms of, those are the facts. What are on the left here, what are some of the, the driving forces of those behind those facts? And so the left side's kind of the sad side. The right side is what are some, the promising things that are happening. So, Dr. Schroeder, you talked about the access, and I'd love for your thoughts on the first point, and maybe in terms of like a little maybe education on maternity deserts. I know Dr. Dimes has done so much research around that. So a little color from you on the driving force of the first, the maternity deserts, and then the promising results. And this gets into some of the advocacy that you're doing. So I would love your thoughts on this first point.
Listen, I'll do the top line. So let me talk, squarely identify a maternity care desert. It's a county. So let me even take a step back. There's a maternity care desert report that the March of Dimes puts out annually. Our last one is on our website. So please go and, www.marchofdimes.org. You can look at it. And it is really great data that looks at county, every state down to the county level, and really looks at where we have counties with no provider, so no family practitioner, no midwife, no OBGYN, to deliver maternity care, not only to see them as an outpatient, but actually to deliver in. We dive into the data visually. It's really quick to look at. And I think we've done a beautiful job of really highlighting that. And we do get into granular, how many miles it is to drive to a place to deliver. And some places it's flying. Think about Alaska. But and where these deserts are across our country, obviously you'll see a swath across the Southeast. Obviously the South Dakota, one of the largest places, longest distances to drive. But we also talk about family access to family planning. So again, these are, places to get to. We talk about what is the disparities that contribute to this. So you're talking about Black and brown women, you're talking, right? And if you're in these places where there is no access, we know that there's less prenatal care or adequate prenatal care. And we know the statistic that you're 3 to 4 times more likely to die if you don't get prenatal care. I always think of prenatal care as really as preventative care, right? Is really the model that it's set up. But as we talk about maternity care deserts, we also dive into some of the other things in our report. So I highly recommend others to look at some of the things that we're doing and advocating for around telemedicine, and which are some solutions. But what we're really leaning into and what we have leaned into is extending postpartum. We know that you don't recover after 6 weeks, right? After having a baby, or even 8 weeks after having a cesarean section, right? We know that that full year of coverage really, starts getting the diabetic, the hypertensive, the mental disorder, right? All of that wraparound. We know we've done this for moms. We've advocated across 43 states are now extending that postpartum care. And so that's where we really lean in. And we've been leading into, as well as midwives and doulas, because we know the data there. Midwives are huge supporters of, extenders and partners in this as part of the solution, as well as doulas to better our outcomes. So these are all on a lot of stuff on our report, but really what we do with advocacy. We have a huge government affairs office that our March for Change is coming up in the first week of March, where we'll be on the Hill and talking to our representatives. And this is a big aspect of what the March of Dimes actually does to try and change what we're doing. So I'll stop there because I could keep going, Susan, right? You're going to have
this is, we could probably do an hour just on that. And I love your report. So thank you so much for that. If folks haven't seen the maternity desert report, to definitely take a look at that on the March of Dimes website, and the work you're doing in documenting that. And also, as you said, the advocacy you're doing, have done and continue to do on expanding the postpartum coverage and expanding the reimbursement and access to doulas and midwives as well. Taking a look at the second driver, maybe I'll speak to that one. The rising clinical risk factors. I mean, this is we're seeing at Progeny Health, and I'm sure many of us on the call are seeing this, right? The rising comorbidities. We know in our country, we have many citizens who have diabetes or obesity, hypertension, and then they become pregnant. And so you not only have the pregnancy, which is a strain on the body, but also these comorbidities. And so that is one of the key drivers in terms of, I'll say on the positive side of promising responses is in order to successfully impact these risks, we're making it easier to have earlier identification of pregnancy. And I'll talk about that when we get to the case studies. But in order to address these issues, you need to be able to have an earlier identification of a pregnant person, as well as earlier identification of those risk factors so that they can be addressed. And one of the ways we're making it easier is for people to basically self-enroll. So rather than figuring a health plan, having to figure out that they're pregnant, having the person basically know there's a resource, raise their hand, and basically self-enroll via a maternity app. And so in our case, what we're seeing is like 15 to 20% of Medicaid members are self-enrolling early on using the app. And so that's a positive. That's a positive response. So
yeah, I love seeing technology really move the needle, and that's like that's the best. That's where that intersection is huge, and that's what we should be doing for all our moms and babies, is getting them. 1 in 7 pregnancy admission is due to cardiovascular event. So preeclampsia, hypertension, gestational hypertension. So the sooner you get that in, better. I mean, I'm here on my OBGYN soapbox, right? The sooner you're identified as pregnant, right? The sooner you can get that under control, there's a better outcome on the other end. I get excited about thinking about using this, Susan, to really get that self-enrollment that's a big moment.
Well,
that's fantastic.
you're going to get excited about this then, because speaking of, the 1 in 7 of why pregnant people are hospitalized is in terms of the use of technology. And I'll just say one thing before we move on to the third and fourth driver, is with the app, our case managers can actually see what content the members are engaging with. And so if a member is looking up headaches, for example, headaches in pregnancy, that is a potential, indicator that they are suffering from. I mean, why would they look it up if they didn't have a headache? And so maybe they're experiencing headaches and maybe they have hypertension. And so it's a flag for our case managers to connect with a member, make sure that they speak to their provider about this. So I agree with you. Technology is helpful. And of course, humans are equally important. Can't do it all with technology. So in looking at the, I'd love your thoughts on the third and fourth driver.
Sure. I'm not sure which one to do first, so I'm going to do the fourth just because, and then we can backtrack up to 3. But, we're doing a ton in the doula space here. So we do a lot of training when it comes to implicit bias training. We do a lot of education for providers, medical students. That's one aspect of the systemic bias that we're trying to help. We do a ton of education at the March of Dimes, but and that mistrust of the system, we know in line with the doula work we've been doing for policy is to help train, supply and demand for doulas is a little bit, right? We'll say, there's a huge demand and, not always a big supply. And we don't want doulas to burn out and we also want them to be integrated into the system. Doulas can work in the antepartum space, the intrapartum and the postpartum. So to really think about that, that's before you deliver, right? During delivery. And then after, that aspect of that 80% being preventable, right, of death, getting doulas into the system is key to one of the solutions. And so we have a huge partnership with CVS. So this goes to partnerships, our CVS Foundation. So a foundation working with a non-for-profit really to work on a work stream, if you think about it, and really trying to get that on the advocacy side, trying to get them reimbursed. So this is where that integrating in that partnership and working together within the healthcare system makes a difference and where we're trying to focus. So and be collaborative and really highlight best practices. So I'll stop there on that one, Susan, and then I can dive into 3.
Yeah,
but
no, I love what you shared in the work that you're doing there. It's fabulous. Yeah, let's jump to 3. Go for it.
Yeah, so we, in collaboration with our collective Impact, I think it's in Houston, Chicago, and Miami, we're working alongside Unite US to better understand and improve referrals for SDOH needs. And it's exciting because our main focus right now is to establish referral infrastructure both to doulas, as we just started, and from the doulas to services their clients might need. So it's listening in the community, right? Like, let's really talk about how you partner the right way. And it's enabling, really enabling doulas, right? It's empowering doulas too, right? To kind of send and refer and be part, and they'll receive electronic referrals, et cetera, to really be part of this social service provider that's a little different, right, that we've done before. And so progress is being made and we're measuring outcomes along those lines, but really excited to see that move along with Unite US, their collective model.
Yeah. Thank you for sharing that. And I love these partnership examples that you're giving of this collaboration. It just excites me thinking how powerful it would be if all of these contributors are working together. So looking forward to talking more about that collaboration in a few minutes. Before we go on, I would love to go to a poll to get your input on what factor is impacting, from your perspective, what factor is impacting maternal and infant health? What factor impacting maternal infant health is your top priority? The access to care, maternity deserts, the rising clinical risk factors, the non-clinical drivers, the social drivers of health, and then systemic bias and mistrust of healthcare. And if you feel like it's something else from your perspective, just feel free to click the other button. And then in the Q&A, just type in what the answer to other is, if that was your answer, because we might be able to get to that during the Q&A, if there's another priority. So while people are taking them, it is a hard one,
right?
It is.
I thought other was good. This is why I hate, right? I've taken so many standardized tests in my lifetime, right? You're like, okay, where is all, E, all of the above?
I know. Well, so we're not allowing anyone to do that. So,
I
Dr.
know
Shaw,
you're holding it.
if you were forced to pick one, what would you pick? Or
Ooh,
from what? I know, it's hard.
Yeah, I mean, listen, I highlighted the access to care. I absolutely think the systemic bias and the mistrust of the healthcare system is much bigger than we identify and talk about. And there's no doubt about the clinical risks. I mean, that's that's where I come from. But I'm actually going to push on the SDOH. I actually think that these are the non-clinical health drivers. And I think if I had to rank, I think that's what I'd love to do here. As I said, E, all of the above is where do you rank the biggest one? And I do think, I guess I look for, if we could solve for that, I think we might get, and that's where we're trying to come in, because we know providers can't do all this, right? That's part of this, Susan, is there's no way for the midwife
busy provider, right?
Right. You can't burden the provider with all this. And I guess that's my bias to all this, right? Is that, but I guess that when I go to look at the answer to this, I would start to rank it and that's where, because we know these all influence, but I think where we make the biggest change. Oh yeah, there you go. That's cool. I love seeing it. Yeah.
Very interesting. Very, very interesting. So it's pretty evenly split on the first three. Interestingly, we did a poll on LinkedIn this week, and it was access to care and mistrust, systemic bias ranked high. And that was a more general population. This is the MHPA respondents. So really interesting to see kind of equal.
Yeah, and I want to thank everybody for responding, because I know some people just let polls go by. So let me say, keep answering, because I think it helps, right, understand and lets us continue to talk about it. But it's good to hear.
And for the two people who put other, we'd love to know in the Q&A what your thoughts were there. So, well, really, really very interesting. So thank you for that. All righty. So now, oh, super excited. We're now going to turn to some real world examples. So not just talking hypothetical, but real world collaborative examples. So Dr. Shiro, I just look forward to you walking through two case studies.
Yeah, I mean, let me start with, Susan, imagine if all the contributors, right, were working together to really, and how powerful that can be. And that's where I hope this conversation continues to generate. And really excited about what we've done. We actually, so I'll start on the left for our green cars for kids. This is something that, bubbled up out on one of our markets in Florida. And we're using electronic vehicles to bring patients, right, to the clinic to be seen. And they obviously have child car seats for safety. Love that it's electronic vehicles, right? So we're going green. And what, you can read the slide that we literally have provided transportation for these patients to get to these clinics, how operationally that then flows through, right, the reduction of no-shows, right, and that you can project that cost savings to the clinic itself, and that we are serving the populations at most need, right? And the Haitian Creole population in this particular was really important. And just thinking about when you start looking at where are we actually impacting, we are impacting riders from zip codes that are, right, super in need and high risk, and they were on, I mean, as a provider, I think, oh my gosh, you're on time for your appointment, how the rest of my day flows, to be able to, right, throughput, you know, it's an operations management problem, right, that happens. So I get really excited to see a project like this. I love that it's green. I love that this bubbled up from a market, and really the return on investment for the investment is in 6 months. We, you know, this pilot, you know, proved and I hate to say it that way, but as a business model, you have to go back to that, right, Susan, and say this works. Not just outcomes, but we actually, the return on investment was humongous. So excited to see this as
yeah. I mean, that's like win-win-win. I mean, for sure. And what you said earlier about the prenatal care being so key to improving or preventing mortality in the pregnant population, having this program really speaks to that as well.
Yeah. So then, you know, the other program that we have is our postpartum coverage. So think about, you now have extension of postpartum care, but you don't know as an individual, what does that really mean, right? What is that for me as an individual, the provider, the community, you know, okay, so that legislation got passed for the state. What exactly am I supposed to be doing? And so extending that benefit, what our long-term goal was to make sure that patients received, right, their care after pregnancy. And so we did a ton of marketing material, but really about education for resources for patients to understand. We did it in different forms, right? So it was actually video as well, English and Spanish, to drive patients so that they knew what was covered and what wasn't, and actually did that for the providers as well, so that and you know, we use social media as well, but you know, you get where they are to be able to tell it, like as a patient, to know what's covered and not covered, right? We all know that can be some of the most difficult challenges to get to, is that they don't know, and so they're not using the services that they actually have covered. So on one side, we have just sort of the, you know, attacking an SDOH and an access issue, and the same thing, just a different way of attacking it. And really love that we have driven patients to be able to use this, and we've got partners that are amplifying this education. So yeah, it's one of the other things that
that's such a great example of how your advocacy then, you know, this is an extension of that in terms of then the awareness of the outcome of the advocacy. And what I love about this is there's 3 different entities here who came together to make this happen. So again, a great example of collaboration.
Thanks. Yeah, we get excited about kind of when it comes, right, when you can really get to the patients where they are. So I'm excited to hear about your collaborative work.
Yeah. So thank you. Me too. I love talking about. I love the collaborative models we have and our partners. And this is an example I wanted to share today as of a partnership that really demonstrates the key the point of today, and that is no one person, no one entity can solve it all, and why these partnerships are so important. So this is an example of Progeny Health's partnership with a Medicaid plan in Florida that really shows how a comprehensive and integrated program leads to an optimal member experience. Progeny Health has a comprehensive program from pregnancy to postpartum, 1 year postpartum, and also includes NICU care management when needed. And so that ensures all the gaps from, you know, conception essentially through year 1 of life are covered. And we know that comprehensive programs, they also require collaboration, because in order to maximize the ecosystem of resources and provide the biggest impact to a population, you again, Progeny Health, a health plan, can't do it all alone. So that's why partnerships are so important. And so in this specific case study, what we've done is we've incorporated the resources that the plan has. And in this case, the plan has a doula network, lactation partners, state and community funded support that we tap into and help members access, and also behavioral health in order to help members, and also ensure not only that members can access those services, but that they're utilizing them to the maximum need possible for that member. So we do more than just giving a phone number out or a referral to another resource. We're really closing the loop and reducing the barriers to access for that member. So really ensuring that they get connected to the support that they need. And so in this model, we're working with all pregnancies and across, as I mentioned, across all pregnancies and also all NICU admissions. And some of the outcomes that we've seen with this type of really robust collaboration include, as we talked earlier, the engagement earlier in the pregnancy, earlier identification, engagement earlier, and also engaging more often, and keeping that engagement throughout the pregnancy. So we are there for the plan and the member throughout that journey, and really leveraging that whole ecosystem of resources. So pleased to share that case study. And I really would love to hear from you all in terms of like the barriers from your perspective. What factor is the biggest barrier to a collaboration for your organization? So there's again, you can see the options here. The no funding for an initiative, internal leadership constraints, legal restrictions, don't really know where to start, kind of overwhelmed, like what is the best solution or other. And again, if you do select other, feel free in the Q&A to put what you think the biggest barrier is.
Susan, I have a question for you since you asked me.
Oh.
So when you think of the partnerships you have today, why are they successful, right? And what's been the health plan's kind of role?
Well, I mean, I'd say good question. I'd say when I think of why a partnership such as the one I shared and others have been successful, I'd say it's really I'd say three things. One is the corporate priority is a must. So there must be a priority on maternal and infant health, as well as a priority to collaborate for the maximum outcome for the member. The second I'd say is transparency. So it's well enough to say, hey, let's partner together, but how does that partnership actually work? And so in the case study I shared, the relationship is one of transparency, sharing member data, claims data, sharing information on our end with the plan, sharing successes and challenges, all in service of the member and continuous improvement of the program. And then, of course, a collaborative effort in driving engagement. We have, from our experience, we've seen what works well with engagement and can provide a toolkit to our partners, really just partnering on how can we together leverage our assets to drive engagement. So I would say those are three things. There's probably a very long list, but those are three things that come to mind.
Good, here we go.
Yeah. Okay, so that is really very, very interesting. Okay, again, and the other, would love to know those thoughts in the Q&A on the other. So that's really interesting. So number one being no funding for new initiatives, leadership constraints, and then don't know what solution or community partners are available. So kind of a mix. So, well, thank you for that.
Yeah, it's really, it's interesting, right? It's interesting about the funding initiatives versus I don't even know where a solution would be. So yeah, kind of tied to each other, I think.
Yeah, I mean, I think, and that's what we wanted this. I mean, this is real world. I mean, we all agree in theory partnerships are good, right? But how do you make them happen, and what are those barriers? So appreciate that input. So, okay, speaking of barriers, let's take a look at breaking through those barriers. And this really gets to some key actions from today. And there are 5 here that are outlined. And I do think that the MHPA membership, Medicaid health plans are really in a unique position to drive collaborative models. And that's why Dr. Stroh and I were really excited about the opportunity to be with you today. You all are mission driven and really active members in your community and have relationships with community-based organizations and other resources. So uniquely poised to break through those barriers. So the first key action for driving meaningful collaboration is ensuring that maternal and infant health is a corporate priority. Everyone in your organization, it will take everyone to tackle this issue, and it also impacts every single department. No one department is immune from this impact. For example, like the maternity deserts are impacting your network team. An unmanaged maternity population is going to cost more and take funding away from other initiatives such as MSK or cancer, for as examples. And then, of course, of the top 5 expensive diseases such as obesity, diabetes, and cardiovascular, high blood pressure, those are impacting the risks and costs. So ensuring that everyone makes it a priority is first and foremost. From the second initiative action item of breaking through these barriers is taking an inventory of all the benefits you offer and the partners you're already working with. And when we looked at the poll, one of the high answers was not knowing where to start. So this is a great place to start, is doing an inventory of who you're already working with and how are those services knitted together or not knitted together. Are there other areas such as telehealth that could be supporting the needs of your population? Is your telehealth provider collaborative and open to that? And if not, maybe there's another one that is, for example. So really taking an inventory. And then this third action of breaking through the barriers is assessing your program through the eyes of a member. Is your program easy to understand? Is it easy to access? Are you creating opportunities to build member trust? Are you solving for non-clinical health drivers? So really assessing through the eyes of a member. The fourth is integrating with partners that understand your needs and are willing to collaborate. There are many, there are many organizations out there who's open to really partnering, listening to you and listening to your members, who's willing to address the whole person, the whole family needs, and build that trust with your members and to collaborate with your providers for maximum impact. So really looking for those partners that are willing to collaborate, because again, no one partner has all the answers. Collaboration is essential. And then the last is to be in action now. Don't wait for an RFP. Start now so that when RFP comes out, you're sharing the results you already have, not what you're going to be doing. So I think that's really key. And actually, with that last one, Dr. Sherrill, this is one I'm thinking you probably have a lot of thoughts on how you can help, how the Market of Dimes can help with regards to being ready for an RFP.
Yeah, I think of a couple things that, like, no one partner or solution, right? I love how is perfect. So I think you do that top kind of 4, and then do it, going in, figuring that part out. There's of that, what you can do and what you can't do, and what you might need really help with, and being right that getting ready for your RFP is going to be huge. And there's some of us who have done this stuff before. I mean, right. And there are others who haven't. And so, right. And understanding that that's okay. Like, it's okay. Like, partners can help you here in that sense. And so, just as we answered the poll of, I don't know where the funding is, or like, this is where those collaborations and communication and hourly talking about what you're trying to address and what you can, level setting kind of that. And I love this slide. I actually think this is fantastic. But this being, knowing where it's coming and being able to really be a partner, and where that partnership could lean in to help you, right, would be fantastic. So,
yeah, thank you for that. Yes, don't call the day it's before it's due. Be in action before the RFP even drops. So, love that. Thank you. So I'd love to use our remaining time. We have a little bit, about 15 minutes for questions, to hear your comments. Certainly following our contact information is here. You can reach out to Dr. Stroh or to me with any feedback or comments. And would love Wendy Milligan, who's been kind of monitoring the Q&A coming in to, we're ready for some questions.
All right, great. Well, thank you. First of all, what an energizing conversation. And there is a whole host of questions. So I don't think we'll be able to cover all of them, but we will make sure to coordinate with MHPA so that we can get answers to any questions that we don't have time for. But let's go ahead, Susan. This is a question for you. And I think also, Dr. Sherrill, there's also an opportunity to add an angle of what the March of Dimes can do from a community aspect. But how should a health plan determine what partners to work with? I know you've talked a little bit about that in that wrap-up summary, but what should they be looking for in partners? There's a lot of different organizations out there. So what would be an optimal partner for a health plan?
Yeah, that's a great question. I think that what I would say is first start with assessing, does that partner have experience working in the Medicaid space? That might sound kind of basic, but start with that fundamental. Do they have experience in the Medicaid space? Is it an area of strength? How many years of experience? Is it a focus for them? So that's the first thing I'd say. And then in terms of expertise, I'd look at, do they have experience? Does a partner have experience in your geography? Do they understand the nuances of your population, the requirements in your state, the nuances? I think we, with the case study I shared, we ensure our case managers have our Haitian Creole speaking. So do they have the language, and does that partner, have that experience that you need for your geography? And then I think the third thing I'd say is, what is their experience and focus in maternal and infant health? And are there examples they can share of the work they've done? And then last, are they open to collaborating? Can they give examples where they've collaborated and partnered well? And then I think last is speak to others. I mean, the MHPA community is such a strong community where speaking to one another, have they heard of, what have they heard about a specific entity and the quality of their work? So those are a few of the things. Dr. Stroh, anything you'd add to that, or a different perspective?
I mean, I would add, that partners that use data, right, to drive where to focus, become their subject matter experts, right? Or are your subject matter experts, and you should be leveraging that. So I think it's really important to look at the community that you're in and you're serving, and use the data that's there to, I'll give the maternity care desert report as one, right? Like it should be driving us to the solutions in the places we need to be. I would also say I love that, particularly partnerships that have worked well have been that we're laser focused on what we're trying to solve together, that we're not trying to, right, maybe boil the ocean, but you're trying to solve, and again, I love the barriers and really thinking about how to internally think about where to, narrow down to approach, but really coming at it with the data behind it, and then really focus on what those solutions would be so that you're not trying to boil the ocean. So.
Great. Appreciate both of your answers on that. And one point, Dr. Sherrill, that came in, I'll weave this into another question, is when you talked about the green cars for kids initiative, there was a lot of questions that came around that. Using that as a community example, how would, if a Medicaid plan, managed Medicaid organization is looking for a transportation contract, is that something appropriate to reach out to your organization and see how they could help support that initiative and get that in their community? Or is that a good example of a way that they can utilize the March of Dimes?
So I would say right away, please contact us if you're interested. We would love to discuss and expand this program. I mean, we're super excited about that. So I would, without question, this particular program where we are now isn't using, the Medicaid MCO, but that doesn't mean it can't be, or that we wouldn't. We really love this program because honestly, if you're getting 100% of your patients in the right where from a financial model, it looks fantastic. It really has a wraparound of what it's intended to do. So when I look at this program, we are very interested in expanding it. And if others are in support, they can email myself. They can email Kay Ernst, ERNST @marchofdimes.org, because we're very excited about the success of this and would love to do more. So
great, appreciate that. Here's another question that is for both, but I'll go ahead and turn it to you, Susan, first. So you both mentioned about collaboration with health plans and with their partners. So we haven't spoke too much about how we collaborate with physicians or the providers. So can you speak to a little bit more, Susan, about how do we include the physicians as a part of our team and what that looks like in terms of collaboration?
Yes, absolutely. And physicians and their teams are a key stakeholder, a hugely important stakeholder in the success of a maternal and infant health journey, no doubt. Our maternity case management team helps ensure that our members complete their prenatal and postpartum appointments with their OBGYN. And I should say, just taking a step back further or earlier, and that is making sure that they have an OBGYN. So if they don't have a provider, helping them get access to a provider who will accept them and has availability for them. So making sure they have a provider, get to their provider. We see ourselves as a partner with the provider in covering that gap in between visits. So helping to manage the conditions, the diabetes, the blood pressure, and alerting the practice if something significant occurs between appointments, and helping members follow their doctor's recommendations and getting ready for that next appointment. And helping empower them. I mean, it's very intimidating, being a pregnant person and going into your doctor and helping them just advocate for themselves and help them advocate for themselves and their questions that they have. So I see it as a complete partnership between the member and the physician and our Progeny Health case management team.
Great, I love that. And that definitely carries on with the collaboration theme. No single partner can do this. Yep. And we're that connection to help that member have a stronger connection with their physician and with their provider team.
Yes.
Yes.
Yeah, I would add, 5 million things to that. I think we try and advocate for moms to be better in their healthcare, right? And so when I think about physicians, having been one, we can't do everything. And so and what we're asking physicians to do, and this is is more and more, as we look into mental health, just as an OBGYN, mental health and cardiovascular, as it's becoming more complicated, Susan, as you highlighted, right? Yep. That these are becoming higher risk. And so, and there are lots of other things that partners can do. Just as you circle, with a high-risk pregnancy, you may circle all these other high-risk specialties. There's also a layer beneath that. And that's the way, right? So I think of it like I would call in my, maybe it's the endocrine, maybe I'm calling for a diabetic, maybe I'm calling in maternal fetal medicine, I'm getting, the neonatologist together. There's a layer below that, it's the doula, it's the midwife, it's the educational information, it's the SDOHs. So I think that's where partners can help solve for this. And that if we can really lock arm in arm, we can be a lattice of support for that patient, putting them at the center of it. And if I can focus that way, that's where I see these collaborations really being incredibly successful. So.
Great. Dr. Schrill, this is another question for you. You talked a little bit about how you are going out and educating new students and new physicians and providers into coming into the medical profession. And that's one of the pieces that the March a Dime does. Maybe you could speak to a little bit more about that. And also another angle, how could that have an impact on some of our poor outcomes when we talked about Black and brown babies? And
Sure.
is there an opportunity through that education to have an impact on some of those outcomes that we see?
Oh, so, this goes back to the systemic bias that's in our healthcare system and really trying to do implicit bias training. And I encourage all providers to do it. I think it can be illuminating in a lot of ways. And it's not the care teams that do this and do this well. It's not a one and done. But we are part of this training that we have done that has been brought in from hospitals, or has been brought in from payers, or healthcare plans have started this journey. And I think the more that these conversations become routine and a discussion of really putting forth our biases and having that. And again, these are educational roundtables that continue kind of crucial conversations that can be uncomfortable to have with teams, not just the providers, right? But we're talking about medical students, so that these conversations are happening about those biases that come to the healthcare system. And so that really trying to work towards having culturally competent care. And that is really crucial to really focus in on. And there's work to be done in this space. And so that's where we've leaned in to try and change really not just providers that are providing today, but our future providers too, which is why the medical students are so important for that conversation.
Great. That's exciting work that you're doing. That's great to hear. I'm looking at the clock here, and it looks like we are going to run out of time compared to the questions that we have. I think we have time for just a couple more. Susan, this is a question for you. You mentioned around trust and member trust and how that is such a key element to having outcomes. Can you talk a little bit more about what does Progeny do to help build member trust? And then I think, Susan, there's an angle there that you can help us with as well around trust, but we'll start with Susan. So what are we doing to build that high trust with our member population?
Yeah, so I'm so glad you asked about that. I think it first begins with the philosophy, having a member-centric approach, a whole person approach. So what does that look like? How does it manifest itself? And that is, I mean, it's everything from having case management staff, our nurses and social workers who speak the language of the member, who understand their cultural beliefs, and who are there, a team that's really listening for what's important to the member. We know what we hope to maybe accomplish, but that really solving for what's most important to that member helps to build the trust. And I would say the first and foremost, to follow through on what we say we're going to do. It just, we hear the member has a challenge with, they need an OB provider. Let's get them that provider, follow through with that on what's important to them. And I think being that advocate for them, that they can trust, once you establish that, then they even open up even more. So those are a few examples that I can share.
Great, appreciate that. And actually, I just looked at the time here, and we are actually right at the end of time.
Yeah.
I'll give Dr. Sherrill the last word. I know there's a lot of interest around how to get in touch with March a Dimes. Can you share with everyone, how do you get in touch with your local March a Dimes chapter and get involved in the community?
Yeah, realize we're in your community. We are doing marches, right? We do walks, and everyone's like, oh, I don't want to do another walk. You can do it virtually. You can actually just get on our website, become a donor, but you can actually get involved within, whether it's our, what we're doing within the community. It's different in each state. It's not always the same thing. We absolutely encourage you. You can reach out to myself. I mentioned Kay Ernst, also at marchofdimes.org, but honestly would love to be partners within the communities that we're in, and really driving the data and amplifying what we're doing, and would love to see more come in for us as a non-for-profit. It's really getting those partners together that we are aligned with. And so everything that you said, Susan, was like, so I would love others, they can go to our website. They can come reach out to me directly, but would love to be able to direct them to our local, markets that we are and where we're working and doing community work.
Great. Thank you, ladies, so much. At this point, I'll go ahead and turn it back over to Eric. I know we are exactly at time, Eric, and you can give some more logisticals on how folks can get this presentation and PowerPoint, and we can also answer some of the questions we didn't get time for.
Yeah, absolutely. Wow. More than happy to go over time. This conversation has been amazing. Clearly, I think from an engagement standpoint, both in the audience poll questions and the amount of questions that come in, this is one of the most engaging presentations we've ever had. So clearly there's a lot of discussion around this topic. So I really appreciate Dr. Sherrill and Susan taking time out of their day to share their insights and their thoughts as we all look together to advance, this issue forward. As a reminder, we did record the presentation, so the recording will be available on MHPA's YouTube channel if you want to revisit it. And then we will be coordinating with Progeny Health to help, answer any questions that weren't answered, and then also get content out, whether it's the slides or other information that we can share from today's presentation. So keep an eye out for that in the next, in the near future. And then finally, I want to thank the audience. This is like I said, this has been one of the best presentations from an engagement standpoint. So we really appreciate your engagement in both the polls and the questions and your time this afternoon. So with that, I will go ahead and end today's session. Thank you, everybody.
Thank you.